Good morning, everyone. Thanks for being here this morning. My name is Holly Tabor, and I'm a faculty member at the Truman Katz Center for Pediatric Bioethics. And I have the pleasure of moderating today's Ethics Grand Rounds and for introducing our three speakers. But before I do that, I wanted to take a few minutes to remind everyone about the format of Ethics Grand Rounds. Ethics Grand Rounds is meant to be a case-based consideration of an ethical issue in pediatrics. And the case that we present is inspired by actual events, but it's generally modified and intended as a starting place to consider the issues that are raised. And the case is going to be presented by children's clinicians for today's Grand Rounds. And the case presenters today are Dr. Mark Lewin and Dr. Gordon Cohen, both of whom I'm going to introduce shortly. And there'll be an opportunity to ask questions of clarification after the case is presented. And the case will be followed by a commentary by our invited guest, who many of you know, Dr. Chris Feudtner. After the commentary, we want to stimulate discussion and invite you to make your way to the microphones in the aisles to ask questions or if you have comments. And lastly, I just want to mention, for those of you who don't know, that Ethics Grand Rounds is sponsored by the Truman Katz Center for Pediatric Bioethics and is supported by a fund established by Jeff Sconyers and Deborah Godfrey. Ethics Grand Rounds occurs quarterly, and the date of the next Ethics Grand Rounds is scheduled for July 2nd, and will feature guest presenter Dr. Alan Fleischman from the March of Dimes, speaking on the topic, Must Children Be Told That They Have a Serious Illness, HIV, and Research Participation? So on to our introductions. Our case presenters today are Dr. Mark Lewin and Dr. Gordon Cohen. They are co-directors of the Heart Center here at Seattle Children's. Dr. Lewin is an associate professor and division chief of cardiology. He completed medical school at the Keck School of Medicine at USC and his residency training at Children's Hospital of Los Angeles before entering his fellowship at Texas Children's Hospital. His research interests include echocardiography, fetal cardiac diagnosis, and cardiovascular genetics. Dr. Gordon Cohen is the Sam and Althea Strom Chair and Professor in Pediatric Cardiac Surgery and the Division Chief of Pediatric Cardiothoracic Surgery. He completed medical school at Tulane University School of Medicine before going on to do residency training at UCLA School of Medicine and at UW School of Medicine. He completed his fellowship at the Great Ormond Street Hospital for Children in London, England, and his research interests include neonatal cardiac surgery, pediatric heart failure, mechanical cardiac assist, transplantation, and endothelial cell biology. So our commentator today, many of you know, on the issues raised by today's case is Dr. Chris Feudtner. And Dr. Bennett was saying that this is a return to the scene of the crime for Chris with his training here. He is the director of the Department of Medical Ethics and the Stephen D. Handler Endowed Chair in Medical Ethics, the director of research and attending physician on the palliative care team and integrated care service in general pediatrics at Children's Hospital of Philadelphia. Dr. Feudtner's current research focuses on care for children with complex chronic conditions, including palliative and end-of-life care, history and sociology of medicine, and multiple objective decision-making. And we're really delighted to have Chris here with us today. So let's get started with the case presentation.
Just wanted to initially thank Ben for sort of putting this together and organizing the thought process surrounding it. And thank you for allowing me to present these cases. Jesse, did you want me to use the microphone or just to use the...
You could just go ahead and use the podium mic since you're on it.
So just as an overview, in terms of these topics and these talks are going to be on neonatal cyanotic congenital heart disease. And as many of you know, these cases are frequently diagnosed prenatally. They require careful and sometimes invasive neonatal intervention in terms of pharmacologic medications, invasive monitoring in an ICU setting, and surgical decision making. And these all lead to some very complex decisions that families have to make. They often make these decisions with fairly limited knowledge sometimes that they glean prenatally, but oftentimes sort of on the spur of the moment postnatally, just where there's a crisis situation, a child is critically ill. This knowledge base is sometimes solely dependent on interactions with one or two providers who are at the bedside at that moment. Sometimes these choices the families are faced with are quite limited. Other times they're wide-ranging. And these two following cases will highlight this range of choices that families have to make. So this is case number one. This is a child who was diagnosed prenatally. A screening obstetrical ultrasound was performed at 18 weeks gestation. Features raised in the obstetrical ultrasound were concerning for congenital heart disease, and they were therefore referred to Seattle Children's prenatal program for a fetal cardiac evaluation, and that evaluation confirmed the diagnosis of hypoplastic left heart syndrome. This little picture on the left of a pathologic specimen highlights hypoplastic left heart syndrome, which Dr. Cohen will go into in more detail. The family was counseled, and its decision was made to continue the pregnancy based upon that counseling and consultation. The child was eventually delivered at 39 weeks gestation. Child weighed 3.2 kilograms, was stable hemodynamically, started on prostaglandin, and transported to Seattle Children's. An echocardiogram was performed, confirming the diagnosis. So at that point, family counseling ensued. The cardiologist and cardiac intensivist met with the parents, described the confirmatory findings of the diagnosis of hypoplastic left heart syndrome, and several options were discussed with the family at that point. The first option was the standard Norwood surgical palliation as a first-staged repair for multiple subsequent surgeries. We also discussed what's termed the hybrid procedure, hybrid being a combination of a cath lab procedure and a surgical procedure in which the PDA is stented and pulmonary bands are placed. It's a more novel approach that we have been doing now for the last several years. We also had a brief conversation regarding the possible listing for cardiac transplantation, in that is the option at certain centers. It certainly has not been offered as a primary intervention at our center for these quote-unquote straightforward cases of hypoplastic left heart syndrome, but when there's other issues involved, that can occasionally be part of the conversation. And then lastly, comfort care, which would be withholding of prostaglandin, allowing the PDA to close, and the child to succumb to the disease process, was not discussed with this family. The family remained ambivalent regarding their options, and they requested a cardiovascular surgical consultation, and Dr. Cohen in a few moments will discuss how that kind of a consultation proceeds and what that consultation is based upon given the data that we know right now. So this is case number 2. Case number 2 was a child who was not diagnosed prenatally. This child was delivered at an outside institution. Triage received a call from a regional NICU. They had a 1-hour-old child who was a 35-week gestation infant in respiratory distress. The child was intubated on 100% FiO2, had hazy lungs and chest X-ray to your left. The oxygen saturation was 80%. Life flight transport was arranged to Seattle Children's, and upon arrival, the child's saturations had deteriorated to 65%, had worsened lung fields on chest X-ray, and just clinically, the diagnosis of total anomalous pulmonary venous return with obstruction was suspected. An echocardiogram was performed, and this diagnosis was identified, and I'm just going to show you this little cartoon. These red vessels are the pulmonary veins, 2 on this side, 2 on the left side, draining into a confluence, going into what we term a vertical vein, draining into the innominate vein and back to the right heart. So there's no pulmonary venous return to the left atrium. The obstruction typically occurs in this vertical vein. So when we did the echocardiogram, what we saw was this vertical vein and some limited amount of flow through here. We didn't really see the individual pulmonary veins draining into this confluence. So we were suspicious that the diagnosis was more complex than solely this, and so we proceeded to a cardiac catheterization. So the cardiac catheterization was performed, and the diagnosis was total anomalous pulmonary venous return, but that was complicated by severely hypoplastic pulmonary veins. And this is the catheterization. And so this, I'll just play once and I'll show you it again, because what it is an injection into the pulmonary arteries. And you'll see the pulmonary arteries fill initially, right here. And then what happens is the flow then continues into the lungs. It takes a long time to go through these very hazy lungs, and eventually the blood does come back, but it doesn't come back through really widely open pulmonary veins. It comes back through a series of vessels in the lung. Eventually it gets back to a vertical vein and comes back to the right heart. This is a classic image for this diagnosis of hypoplastic pulmonary veins, and this is an inoperable condition. The veins cannot be reattached to the left side of the heart. So at that point, we knew that this was inoperable. The family was counseled by the surgeons, by the intensivists, and by the cardiologists. They were informed this was a fetal condition. Surgery was not offered in this situation. Comfort care was initiated due to the fetal nature of the case. So these two cases sort of highlight two very complex cardiac lesions, one where there's certainly multiple options, the other where there's not. Families have choices to make in one, they really don't in the other. But in fact, we didn't offer the family one of those potential choices in that hypoplastic left heart case. We didn't offer them the, quote, comfort care that oftentimes is. And that's become a sort of a moving target in our field, and that's really what the nature of this conversation is about. So I'm going to turn this over to Gordon, who's going to continue the conversation.
Good morning. So after the diagnosis has been made and the family has met with the cardiologist, the referral is then made to surgery to discuss what the various surgical options are. So the Norwood procedure for hypoplastic left heart syndrome is the standard and traditional therapy for this condition. It's really the first of a three-stage palliation. Remember that these are patients who don't have a left ventricle and they have hypoplastic left-sided structures, including a hypoplastic ascending aorta and aortic valve. So these are not patients who can ever have a two-ventricle circulation. They're always going to have a one-ventricle circulation where the right ventricle serves as the systemic ventricle. So they undergo a series of 3 operations, the first one at birth, which is the Norwood procedure. The second one is at 6 months of age, the so-called bidirectional Glenn shunt, which I'm not going to go into. And the third one when they reach approximately 15 kilograms of weight, which is the completion Fontan procedure. When this operation was first described in the mid-1980s, the survival for the procedure was in the 20 to 25% range. So without surgery, mortality was 100%. With surgery in the mid-1980s, it was roughly 20 to 25%. But now if we fast forward more than 2 decades later to 2009, there's been a lot of progress with the outcomes, especially over the past 5 to 7 years. And in 2009, there are actually a few centers in the country who are achieving approximately 95% discharge survival. Here in our institution, over the past 4 years, we've achieved a survival of 90% survival to discharge. And if you look at the Society of Thoracic Surgeons database nationally, participating centers, and participating centers are big centers, small centers, it's an elective decision to participate within the STS, have an approximately 80% survival to discharge. But also associated with this condition is an interval mortality, which means that we do the Norwood procedure and we send the patient home, but a certain number of patients die before they come back for the second operation. And historically, that interval mortality rate has been roughly in the 20% range. And if we look at the STS database, that discharge mortality has improved to somewhere in the 10 to 15% range. At our hospital, we haven't had an interval mortality in the past 4 years. And again, the best centers are achieving 0 to 5% in that range interval mortality. Then when you come back, you have a stage 2 operation, which is the bidirectional Glenn operation, and it is a much lower risk operation. And most centers have a mortality rate of less than 5%. And frankly, people who do this operation routinely through all 3 stages typically have mortalities that are very close to 0%. And ourselves, we haven't had a discharge mortality in 4 years. But over the past few years, kind of simultaneous with the improvements in the Norwood procedure, another procedure has been described, which is the hybrid palliation, or stage 1 hybrid palliation for hypoplastic left heart syndrome. And before I explain to you why this came up, let me just tell you one other bit of information about the Norwood procedure. In order to do the Norwood procedure, we put the patient under cardiopulmonary bypass, and we have to drop their body temperature to half of normal, to 18 degrees centigrade, at which point in time we have a period of circulatory arrest, which means that we turn the heart-lung machine off, we drain all the blood out of the body, and then we do various parts of the operation. Different centers do it differently. In our center, we try to use what's called regional low-flow cerebral perfusion. We try to give blood to the brain for most of the operation, but there is still a short period of circulatory arrest. Other centers do the whole operation under circulatory arrest, which can be anywhere from 30 to 60 minutes of no blood flow in the body. So people have always been concerned about what are the neurologic outcomes associated with that. I'm not going to go into that because it's another whole topic. But given that, and given the historic high-risk nature of doing the Norwood procedure, and this alternate strategy evolved. And this strategy is, as Mark said a few minutes ago, is a combined approach between the surgeons and the interventional cardiologists. And it's still done through a median sternotomy, and the surgeons place pulmonary artery bands on each one of the branch pulmonary arteries to regulate pulmonary blood flow, and then a stent is placed in the ductus arteriosus, and that can either be placed transthoracically or it can be placed percutaneously through the groin. So functionally what we do is we create Norwood equivalent physiology without using cardiopulmonary bypass, without using a period of circulatory arrest. And so it's felt to be a less invasive operation and less stress to the newborn. But ultimately what it does, it delays the major surgery for 6 months. So at 6 months of age, you come back for your second operation. You still need to have the Norwood procedure, but you're having it at 6 months of age rather than in the newborn period. You still need to have a period of circulatory arrest and low flow, but you also have the bidirectional Glenn done at the same time. But it's been proposed that this may be less stressful to the patient overall. And then ultimately you still undergo the Fontan procedure at 15 kilograms. At the center where this really originated from, Columbus Children's, they've been able to now, after undergoing a learning curve, achieve a 95% survival rate to discharge. We also have used this procedure here, but we've reserved it just for the very, very high-risk patients that we felt would not ultimately survive a Norwood procedure, and we've been able to achieve a survival similar to our own Norwood survival. So our discharge survival is about 90%. But it does have a higher interval mortality rate, and that's a little bit difficult to sort out because some patients have actually been palliated for other reasons and have been actually their endpoint has been to go home and die at home because they had other associated conditions that made them not a candidate for any further treatment. But anyway, some of the considerations for this procedure that are not well understood yet is what are the risks and benefits associated with this procedure. Teleologically, we can make the argument, well, this is less stressful and it's better, but we don't actually know what the implications are of having retrograde perfusion through the aortic arch retrograde up into your head rather than antegrade perfusion. We don't know the implications of that, and there's a lot of discussion about that at the moment. And then finally, as Mark mentioned, primary heart transplantation. It's not offered as primary therapy by the vast majority of centers. And here, and like most other centers, we reserve it primarily for patients with either poor right ventricular function, where the right ventricle would not be suitable to serve them through life as a systemic ventricle, or they have a significant electrical abnormality where a Nor would be poorly tolerated. Of course, transplant is limited by organ availability, and it requires lifelong immunosuppression. But the survival rates are actually quite good for it. 95% at 3 months, 80% at 5 years, and 70% at 10 years, which compares similarly with what we know about hypoplastic left heart syndrome and staged palliation. But there is a risk of mortality associated with being on the waiting list. So I'm not going to discuss the TAPVD case because Mark already mentioned the fetal nature of it. And so, want me to follow up with a slide, or?
Here's the long, awkward pause while you try to close out one slide and get another going. Well, I'm extremely pleased and feel very privileged to be here this morning. I want to thank both Dr. Lewin and Cohen for setting us up to think about something. I'd like to actually say at the outset, I really come with no agenda. I say that to many families in so many words that when I first talk to a family that's confronting a very difficult decision, I try to make it clear that I'm not there to either guide towards palliation, even if I'm coming as the palliative care rep, or when I do the complex care team, and I can be a very aggressive clinician for curative care, or at least radical life prolongation. I come with no agenda. I need to figure out what the family is thinking and what the consensus is about what is possible for this child, what the situation is. But let's move ahead. First, I have nothing to disclose. I want to make some promises up front and to offer a couple of thanks. And then I want to focus down of the many issues that we talked about with the details, the very important details of how the hypoplastic left heart syndrome, that situation is changing over time. And how do we come to cut points where we would say what used to be the right way to do it is no longer the right way, and that we need to change the standards of what we're not only performing but also what we're talking about. The way that we're going to do that, I'm going to propose, is to think about whether the overall task of talking to a family and talking about therapeutic options can be divided, parsed out into separate tasks, and then to think about how those tasks have different duties attached to them, obligations that we have, and how those duties actually are tied to different stakeholders. I'll try to make all this clear. And lastly, because I'm very much a pragmatist, I'd like to spend some time talking about how do we have these more difficult conversations if we are going to raise the issue of palliative care, or with a family where the surgery looks like it's very unlikely to have any implication of survival. Do we even mention that some centers would potentially try a Hail Mary attempt at actually doing an operation that we think is incredibly ill-advised? How do we talk about that in a way that isn't going to take hours to talk about and will feel genuine? All right. I want to be as straightforward as I can. And throughout this, I'm going to try to be clear, let you know what I'm thinking. I'm going to tell you the aspects of the argument that I'm going to make that worry me, that I think are incomplete, there's still open questions, and I'm going to try not to oversell the approach that I'm offering. I want to thank specifically Ben for sort of pulling this together, and Fred Ravara, who, as the editor of Archives, actually accepted a paper by Alex Kahn. Alex, an intensivist down at California, had actually some years ago surveyed pediatric cardiologists, asking them, what would you do if you were the parent of a child who had a hypoplastic left heart syndrome? What would you pick? And the data that I think is problematic, we need to own it. Maybe we can explain it away, but at first glance, 90% survival. You still had half the cardiologists saying they'd want to hear about palliative care, and because they may pick that for their child if they had one. Does that say that this is still a reasonable option even as the technique has improved? Or is it that people are just using outmoded data? Gil Warnowski, who we invited to actually write a counter-argument, said this is just a problem that the field has changed so dramatically over the last 20 years that people are still remembering the horrific 1980s, and that in the 2000s the situation has changed so much that we need to reboot our thinking about what's the appropriate way to counsel people, that it's no longer appropriate to offer palliative care. And Gil argued that not just by looking at the improvements over time, but also doing comparisons to other diseases. If we look at those survival statistics that we just saw, we certainly take care of children and counsel families where the survival, the likelihood of survival is less than that. And we don't routinely say, oh, by the way, there is this palliative care thing. If we think back to what happened with pediatric cancer in the 1950s, with very, very little to offer in terms of any kind of effective chemotherapy, basically none, by the 1980s, that situation had so radically changed that we don't routinely offer to a child coming in with ALL, a previously uniformly fatal disease, we don't offer them palliation. So there could be, and I'm very open to this, a point where we will make a transition to say what was the right way to actually counsel people in one era becomes less so over time. But before we jump to that, I think that we have to deal with how are we going to organize our thinking if things are changing over time. But reasonable people, and I'll, for the sake of argument, say those cardiologists are well informed enough that a group of people, you will find a portion of them, all of you, I still have an enclave over here who wants to hear about palliation. And you're well informed. You may not pick it, but you want to be informed about it. How do we handle that? So my suggestion, as we think about this problem, when is it okay to just stop telling people about an option? Maybe we can also get a little bit further if we think about, we can tell you about it, but we are personally not going to offer it anymore. That other sites might do it, but we will get to a point where we may say, because of reasons of conscience or other things, we're going to stop offering. I'll point out that it's not just about the cardiac conditions we've discussed. Other medical conditions certainly can fit this type of scenario. Cutting-edge therapies. When do we take a therapy that may not have all the data fully in place to say it's superior, but it's the latest thing, we think it's going to be better? When do we shift from really giving people almost a research protocol type of informed consent? And when do we just say, so today we're going to start something new, and actually don't seek consent. And then lastly, I think with the healthcare reform very much on our minds, recent articles in the New England Journal that are actually starting to push back, we are going to have more decisions about, we don't even mention some drugs that are no longer on our formulary. And yet at another HMO, another site of care, you might actually have access to those drugs. How do we talk about any of those issues? All right, informed consent. We know that there are three, and a lot has been written about this, but I think you can boil it down to three main things. To do informed consent right, you need to make sure that the person you're talking to is a competent decision maker. I won't go into that, but obviously they have to be able to process the information. They need to be free from duress or coercion or external influence that is overwhelming. Okay? We'll get back to that in a minute. And then lastly, they need to be given enough information about what the pertinent options are. So the typical language is they need to be told about the therapy that's being proposed and reasonable alternatives, including often non-treatment. That's specifically mentioned in many codes and whatnot. The question that we have to grapple with is what counts as pertinent and when does it become no longer pertinent to mention palliative care or, at the other extreme, because I come with no agenda, the very radical surgery that another center might do that we think is just, I'll be frank here, a little crazy, not likely to work, likely to inflict a lot of suffering and pain. When can we omit those? When are those no longer pertinent? The two standards that are proposed, and if you go across the 50 states of the U.S., because this is largely governed by state-level licensing boards and law, you have two options. You can say either there's a reasonable person standard, that what I'm supposed to tell Holly, if Holly came in, is what a reasonable patient would want to know. What does that mean? Well, they dance around that, but there's a sense that if you were to ask a panel of people, a population of people, you get a sense that most of you want to hear about a surgical approach, most of you may want to hear about a medical approach. How many of you want to hear about a palliative approach at the same time? That might be one way to say, I'll assume you're all reasonable. What percentage of you want to hear about this additional option? The reasonable physician standard, which is not what applies here in the state of Washington, it's the reasonable person standard, is that the community of physicians just doesn't really talk about it by consensus. And this, too, I think you have to say, if we have all of those cardiologists who took that survey that Alex Kahn did, and you have still a group of them that may feel that they need to talk about it, when can we say that the community standard of physician conduct is that we no longer talk about an issue? The open questions, then, that we have to come to grips with is what defines enough information, pertinent information? More importantly, who gets to decide that? I'm the doctor. I get to decide. Well, I think we know that that's probably not the best answer based on all of our experiences over the last 50 years thinking about some kind of balance between paternalism and full autonomy. The patient entirely gets to decide. That's also probably not the best answer. It sounds good, but we realize that there are constraints, both in budget, time, and what's feasible. We need some rapprochement. We need some kind of balance between who gets to decide, and maybe dividing up the tasks will actually help us with that a little bit. And can those standards be quantified? I'm very leery of vague statements like, how long should I talk today? Not too long. Well, tell me, when do we want to finish? Then I can actually target it. How many of you would have to agree with something before I would say, okay, this is now standard? If it was just one person out of an audience of 100, is that enough that we could say that's likely, or would it need to be 10%, 20%? That type of quantification would allow us to actually, I think, be more secure that we're behaving in a consistent manner. And then the second open question is, if I mention something, okay, there's these three options you have, does that obligate me to actually provide it? If I feel like I owe it to you to tell you about it, but morally, policy-wise, maybe even legally, I don't think we can enact that, or I personally cannot participate in that, I'm going to suggest that we can distinguish those two acts. And in so doing, can actually be able to navigate where we're going to tell people about options that we will not participate in. So the framework then, and we'll be able to get through this, I think, in about 10 minutes, is threefold. I'm going to separate up the tasks of informed consent. We're going to talk about the duties and then add these stakeholders. As you march across giving informed consent, I'm going to start with the first task. You give information. You offer up, here's what you need to know. And here's what we at our center can offer. Here's what I specifically would recommend as the best option, I think, for you or your child. And then we can talk about that, deliberate, and choose. I have this zeroth issue that we'll come back to in a second. Let's suppose, just to make this clear, that option A, B, and C are 3 different therapies. Basically what this says is I owe it to you to talk about A, B, and C, but here we don't do C, so you just need to know that. And really, I think the best option for your child is A, and the parents might pick option A. Let me make that even more concrete. In the example that we're sort of talking about, Alex Kahn would basically have said, there are 3 options available for parents of children with hypoplastic left heart. So in scenario 1 is you inform about all 3. You have to, according to Alex, sort of offer, because he doesn't distinguish informing and offering. They sort of come together as a package. And he assumes that people are still going to recommend the Norwood, but at least it's there on the table, and the parent gets to decide, because we've empowered them to know that they even may want to go to another center and get a transplant. But at least they know about what the options are. Scenario 2 is we've made a very thorough decision that we're no longer going to offer this as an option. We think that the survival rates are sufficiently high, that the morbidity is sufficiently low, that we will no longer offer palliative care. I'm not arguing for any of these. I'm just trying to map them out. And we still inform people about them for the same reason we inform them about the cardiac transplant, because they have a right to know that if you were to impanel a group of people, they would want to know about this. We let them decide. The final option is to just sort of take that off the plate, take that off the table. Palliative care is no longer even mentioned as an option. Which of those should we pick, and how do we think about that? Before I jump to that, I want to pause and talk about this task 0. The more I do counseling with parents, the more I think that, I'm going to put this bluntly, that today's discussion may not really be where the action even is. That often the very difficult decisions, the ambivalences, are upstream from the decision that we're focused on today, whether or not to do a Norwood. It's how they're actually trying to make decisions of what does this mean, what is going on here. I'll tell you a story. It has nothing to do with hearts. It has to do with a 9-year-old girl who had cancer, neuroblastoma, and had been in the intensive care unit in our hospital for quite some time, and was getting progressive abdominal distension to the point where she was really not able to be ventilated. So much distension upward into her, pressing against her lungs, and was coming close to needing respiratory support. The PICU team, as you can imagine, was very apprehensive about this and had detailed the mother at length about impending respiratory failure, intubation, do we want to do a resuscitation? And the mom kept saying, no DNR, no DNR. So they asked me to come by, and the palliative care team to come by. And I'd heard enough about the story that I was intrigued. Come back to this concept of being curious. And I walked into the mom and I said, I wish things were very different. Can you tell me what's going on? And the mom said to me, well, for the last 4 years, I have been in a fight with the devil. The devil put the cancer in my daughter, and I cannot do anything that will aid and assist the devil in doing the devil's work, which is trying to kill my daughter. So if you're in here to talk to me about a DNR, I'm not talking to you. And I said, oh. Radically different depiction of the situation. It wasn't about respiratory failure. It was about an epical struggle with the devil. It's an extreme example, but I can tell you, 9 times out of 10, when I hear that decision-making has run off the rails, it's because we haven't gone upstream. So if there's one teaching point I'd like to, something to give you, go upstream when you're dealing with these difficult decisions and ask the question, can you tell me what's going on? What does this mean to you? I find the fight against the disease metaphor, I was talking to David Woodrum before I even came in here, and the parents detailing how they've done all these things during the pregnancy to try to get a healthy child. Now, why would I give up now? They're not even talking about the kid. They're talking about their own journey of being a good parent an issue that Pam Hines and I are very interested in. This battle against the devil, this calling to be a good parent. All of those are the zeroth, the task that goes all over the place and may actually dominate decision-making as people are trying to think about what does it mean for me to be a good parent. Now, there are other examples, and I just want to point to these quickly, about, as I mentioned, cutting-edge therapy. Do we tack in another task at the end to these cutting-edge therapies and actually, like a research protocol, make it more mandatory that there's a higher level of engagement that needs to occur, that we don't just allow informed consent to be more casual? Transfers. Do we actually say to people, we do this in other centers where you can't go all the way up to quaternary care, that we actually think surgery is the best option, even though we don't offer it. So we do make distinctions between informing and offering because of constraints on what we're able to perform. There may be settings where we would say, in a given setting, we don't think a Norwood's the best, and because of a particular set of reasons, we may actually want you to go somewhere else to get a transplant. Not saying here or CHOP, but there are definitely centers that would do that. So if those are the tasks, what about the duties, this duties issues? I'm going to divide this into three simple categories. We have a duty to the patient, a duty to ourselves, which needs to be acknowledged and managed in some way, and to society. The patient/parent, we're trying to facilitate this autonomous choice by maximizing their internal control. And we could talk about this at length. I don't want to go into it too much. And when I talk about holistic decision support, it's not just simply giving them information, but it's actually helping them manage their emotions and actually the depictions that they have. How are they actually representing this situation? Something I'm very interested in. And then to minimize this undue external influence, which means me, and how I'm actually framing the decision for them, what kind of information I'm giving them, to make sure that it's not just that they're going to do what I have guided them fairly firmly, even if somewhat invisibly, to do. The second is, as a clinician in an organization, this issue of conscience integrity been in the news lately because of the Bush policy that appears not to be going forward. But when can we say, for personal or professional reasons, we cannot participate in something? We have to be very careful about doing that, to the point of I think we should almost never do it. But to say that we should never do it is too far. We can't abandon our sense of integrity. The profession and society needs us to say, there are certain things that we cannot participate in, because otherwise we have totally become the agent of the state or the agent of society. We need to remain agents, in part, responsible to our own selves. And it could also be that we have responsibilities to manage the organization in a way that we look at competence. Are we ready to do this procedure right? Can we afford to do it? Is it part of our mission? When we talk about conflict between patients and clinicians, parents and clinicians, pardon me, our primary duty is to the child. And in palliative care and in complex care, I see this a lot. A lot of our patients are babies or are unable to talk to us because of cognitive impairment. It's very easy to shift to, like, we're taking care of the parents. Our primary duty is to the child. And when we have a conflict, we often appeal to what's called a best interest standard, what's best for the child. But I'm still waiting to hear a clinician or a parent say, I don't want what's best for the kid. The debate is about what is the best interest. So this standard often doesn't do a whole lot of work for us when we apply it, because what we're arguing about in the case of the hypoplast, is it in my child's best interest to have the best chance of a long-term life? Or is it in my child's best interest to not undergoing procedures that in my depiction of the situation would cause undue suffering? And I'm going to have to reconcile that as a parent. Okay. Society has a stake in this too. We want, politically, socially, we're not always consistent about this, but we want to have effective health care, and we want it to be distributed with reasonable equity. We don't want a radically unequitable situation. How close we come to accomplishing that, we know we have plenty of room for improvement. We also want to protect individual autonomy. This is why every state has laws about informed consent. We have a state's interest in doing that. Let's now tie those duties to a third group, the stakeholders. And the way we're going to do is we're just going to reverse the flow, that those duties aren't just to the patient, but the patient or parent is going to give me some duties. They're going to request that I do things. And myself. I'm going to call it myself. I'm going to say, self, what should I do? And it's going to tell me that there are certain things I need to do. And that could be organizationally. It could also be my conscience. And lastly, society is going to tell me some things to do. So we talked about the stakeholders, patients, families, clinicians, and I mean all of us, healthcare organizations, and this community or society. What I've done here then is to say, as we go across these tasks at the upper row, and I look at all of the stakeholders, who gets to say what duty I should be acting on, what type of information I should be providing? Now, this can be debated, but I'm going to argue that really in the informing realm, it's not actually the patient right in front of me, because you're a bit of a cipher to me. I may know you, I may have known you for a long time, but I'm sort of obligated by a societal standard of other patients, perhaps, of how much I should tell you. What is the reasonable patient wanting to hear? How much information should I provide? And that actually comes not from me, and not necessarily, if the patient says, I don't want to hear about palliative care, they know enough, I don't need to detail them on it. They have been informed, maybe not completely. I'm not saying that we override that injunction not to talk about it. When it comes to offering in distinction, society can say you just can't afford that, or you must provide it, like in tele laws, or organization of clinicians. It's really when we get into recommending and choosing that the patient values come very much back into the fore. Of we provide them with information, we tell them what we can offer in good conscience, and then they deliberate and decide. I won't go into this now, but I think that there's a role for screening tests and whatnot that we do at a societal level to detect problems, that the way we think about situations, that this detection and assessment is very much a part of how the values of the parent are interdigitating with the values of and the way that the clinicians present that information. So let's go back to our sort of open questions. When is non-informing okay? If we go back to this issue that informing is really about a societal standard, not about a patient and not about a clinician, I would propose, and I'm just going to put this out there for argument, that we would impanel a sort of participatory democracy. We'd impanel a group of 100 prospective potential parents. We tell them everything, state of the art. And if we had fewer than, and I'll put it out there again, 1 in 20 said, nope, we need to talk about palliative care. This is definitely a green light. We need to know about these options, cardiac transplant, Norwood, maybe the stage procedure, the hybrid procedure. It's at that point okay. I'm trying to give you a quantitative sense. When few enough people want to hear about it, we can drop it from the agenda. Or it's illegal. And right now, none of these options are illegal. When is non-offering okay? Basically, we're going to tell you about it, but we're not going to offer it. If this is true, that it's actually not about the parent, we don't need to kowtow to parental requests. We want to meet them as far as we possibly can go. But with integrity, there are going to be some requests that we cannot offer it. If we go that far, then there are reasons. There's no supply, materials, or expertise. We lack the capacity or competence to do it. It's not cost effective. We're going to see this rising as an argument. Or we have our conscience. It's either somehow immoral to us. Obviously, we're thinking about reproductive issues very much on this issue. Or there's too much suffering. I do want, and I prepared these slides some weeks ago, to talk a little bit about the word futility. I avoid it as a rule. In part because I think one person's futility is another person's another 10 minutes of holding my child's hand. It's really a question of what we value. So I try to avoid it. We've been burned in our hospital. If parents ever catch wind of that phrase, they can go ballistic. My child is not futile, etc. So I think it's best to just sort of, let's scratch that and say the therapy cannot achieve X, long life. The therapy cannot achieve survival. It cannot achieve survival even for a couple of days, years, months, and leave it at that. That's more precise, and I think it actually fits with what we're trying to describe here. So summing up part one, I want to say we should think about whether we're going to lump informing and offering in one package. And I'm going to say I think we can separate them. And by doing that, we can honor our duties to the patient and society, as well as our own moral obligations. But we need work to actually be able to come up with better rules of thumb as to how much information we should supply. The last bit is that's all very well and good, Feudtner. But how do you talk about that? I mean, you have just opened up a can of worms. And we're going to have parents who are going to freak out. They're already anxious enough. And you're either going to tell them something and then say, but we can't do it, and they're going to be angry with you, or you're just going to stir the pot and make them anxious. Why are you talking about palliative care? You know, my kid's going to survive. All right. I'm going back to my 3 promises that I made to you folks when I started. I often say this to parents. You know, you're just meeting me for the first time, so a few things to know about me. I'm very straightforward. You'll know what I'm thinking. I'm going to tell you how worried I am about something, and I'm going to try not to make a promise I can't keep. Now, with that sort of compact, which when I try to get the residents to do this, they're like, that's weird. Like, you don't do that type of thing in the doctor-patient relationship. I'm actually going to spend time with them today. Like, I think we can. I think it actually tells the family, this is how I'm going to detail you. With that in place, we can talk about informing but not offering in either hypoplastic or a lot of other scenarios. When we think, you need to know about this, I owe it to tell you, but we're not going to be able to offer that to you here. So how does that dialogue go? Okay, so we've talked about the Norwood and this hybrid procedure, and we've talked about cardiac transplant. I also owe it to you, because I'm very straightforward, to tell you about other options that other people would talk to you about, including palliative care. Palliative care is treatment aimed at ameliorating suffering. It will mean we won't do anything to necessarily prolong your child's life. Okay? But we will do a lot of things to try to make them comfortable. Now, I have to also tell you that's what, the way I phrased it there, we wouldn't do it. I would remove that. Palliative care attempts to do these things. At the same time, if I were to not advocate for it, I have to tell you I have such strong feelings about how good we could do for your child with these procedures. I don't feel like I could offer that to you or your child. Or our hospital has a policy, or our HMO has a policy. Even though I think this is a very good drug, I can't offer it to you. Now, here are the things that I could do if you wanted to pursue that. You know, I can make a referral to another center. We could, you know, potentially talk to your HMO, or I can't help you. I have found, in general, that no parent actually gets peeved with me when I expand the options. They say, thank you, not interested. If it ever comes back that things don't go well, and they hear about this, they say, yeah, you told me about that. And I appreciate you being upfront with me about it. So I don't think that the informing piece, and then even me saying, because I've done it in both directions, I could talk about withdrawal of artificial nutrition hydration, where I've said, you will talk to other providers who would say that that's a suitable option for your baby. And here's what would happen, but I don't feel I can offer that to you. And here's my reasons why I can't. Policy reasons, a little bit in our state, we have some law, but also ethical reasons. And the parents have said, well, we're not happy with that, but we respect you for it. And we've had a fine relationship after that. They know where I'm coming from. So I don't think it's that you're going to stir the pot and be left with a big mess. In fact, over time, I think you can have more efficient conversations, especially if things don't go super well, because they know they can trust you to be forthright and complete. So I'll end with this. I think that if we start to think about informing people about options, even if we think they're lousy options, but we know colleagues of ours talk about it, and we know that reasonable patients want to know about it, we can talk about these things. And those difficult conversations aren't necessarily bad or unwise, that they actually show a kind of respect, and they, I think, build trust. And they don't actually take all that much time. And Lord forbid anybody finds out that you left something out. The amount of time that you can spend after that, sort of backhoeing in the information. This is, I think, a more effective way and efficient way to doing it. And that offering those promises up front, I'm going to be very straightforward with you. I'm going to tell you how worried I am. I don't think I can promise you that we could ever do what you're proposing because of the way that our policies are written in our hospital. I can look into it, but I can't promise it. I told you I'd be very straightforward. I don't think that's an option that we can do here. Even though I know that other people have told you your child is suitable for palliative care, not now. And here are my reasons. So as I said, I don't always come with an agenda up front, But that doesn't mean I don't come without my thoughts, my integrity of what's the right balancing act between trying to inform people of the range of options that are out there that they could find and what I think we can offer, and let alone what I would recommend. Thank you very much. Okay. We have time. I'm sorry we ran late. We have time for some questions. I'm putting this potential framework up for people to poke holes at. Sir?
Considerations have to be extended but beyond consideration of mortality. What is the long-term consequences if with survival? Is the child going to be neurologically functional? If they are neurologically functional, when they grow up, what will be the risk for their own children?
Right. Well, I agree with you entirely that what parents often want to hear about is survivorship. They also want to know about quality of life, the ability to think, to go on and have independent living. And there is data, I think Dr. Cohen mentioned it, I work with people who are doing that to actually look at the outcomes. They also want to know the impact on the family. And I did not touch on this, but we know that this is a hard journey. I think that many of the cardiologists who are talking about what they would want to know about are reflecting the taboo topic, which we need to start to feel more comfortable talking about. When are we asking families to do too much? Now, there are standards that we should not be paying attention to that, the best interest standard for the patient. But we know that there's collateral effects of the care of a gravely ill child over time. We actually have a poor sense of, we're doing a study right now of siblings of our children in palliative care. How much is it affecting them? We actually don't have great data on that. In oncology, it looks like they do better than you might expect. But the impact on the marriage and on the siblings, and then the child's long-term outcome, I agree that's all part of this. I backed off of talking about that because I also think it's largely irrelevant for what I'm sketching, which is simply, what do you guys want to know? If you're the potential parents, it's not up to me to try to make a decision about what I should tell you and what I shouldn't. After we give you that information, and you can ask for it, and we can give you details, how many of you still want to know about palliative care?
Well, I'd like to extend it even further. In our first study, published in 1983, of the association between mother and infant prenatal growth, we predicted that there will be an increase in preterm low birth weight babies, which is now being realized. And part of that is, I think, a product of our increased effectiveness of perinatal care, neonatal care, and general care. And this is having some significant impact on the health of our population. Now, the next grand rounds is going to be on early life factors in chronic disease. So it, and the chronic diseases even include Alzheimer's syndrome. You know, it goes all the way up the age cycle. And these things have to be, I mean, I don't have the answers to this, but I think we have to start talking about these
I appreciate
things.
that very much. I don't have, by the way, answers either. But I think more importantly, these are the more difficult taboo topics that we need to start talking about. Can we afford to have a child-centric view, which I'm generally in favor of, but this is an issue that we are going to need to approach as our interventions become more sustained, chronic, lifelong.
And I would maybe follow up on that discussion a little bit and expand that in my experience, there are topics that families feel they're not allowed to ask about. So, for instance, cost. Not only cost in dollars, but cost to families and the integrity of their other children and their relationships. So I think somehow in the early discussion you have to give permission for those to be discussed if they wish to.
Absolutely. And sometimes in that processing, they'll come to a sense that we still want to go forward, but thank you. It's helped me put on the table my emotions and the ambiguities of why I'm conflicted, because I'm afraid it's going to wreck our lives. Mm-hmm. But now I can start to manage that because we brought it out into the open.
And it also gives you opportunities to help them think through that as well. But and then the other, I think, important dimension, you focus primarily on the process. The personalities who perform this process is another very important part of the equation. And I know that we may not have the time to deal with that element, but that's certainly another consideration in how best to do that. What's the best practice?
Yeah, I would say that the thing I'm most interested in now in terms of its import for families is emotional management strategies. I think that we have over-cognitized, if I can use that word. We've made this into very much talking to, above our neck and to one side. I guess it's this side, where we give lots of cognitive information, very rational approach. My mantra is that parents not only think their way to the right decision, they have to feel their way to the right decision. And I think that's true for any of us. If we've got a major problem, a problem that scares us, if it doesn't feel right in our gut, we don't act on it. And while we have lots of suggestions about how to provide information more clearly, when I ask people, have you ever been taught about emotional management strategies, I don't see a lot of hands go up. That's a growth area that we need to focus on. Lots of opportunity. We do manage emotions. We may not just manage them, we may sometimes manipulate them. Figuring out how to do that in the most effective and ethical way, I think, is a huge opportunity for us moving forward.
Returning to the case of the hypoplastic left heart, or you could also generalize this to other congenital anomalies such as meningomyelocele that requires repair and that sort of thing. I'm kind of torn with the idea of taking palliative care off of the discussion when we look at the prenatal assessment with these cases, that oftentimes we offer the family the option of termination because of this life-threatening condition, and families may not choose that, but then all of a sudden they choose to have the live-born infant, and we immediately say, well, now we have a surgical procedure. Palliation isn't an option. And I guess I'm asking for advice on how do you ethically mediate these two things, saying it's okay to terminate, but now that the child is born, it's not okay to choose palliation.
Now, let me be very clear on this. I am not saying that I've advocated any one of those three.
Right.
I'm actually saying I'm irrelevant. The people who need to tell us whether we can drop palliative care as an option are not necessarily in the room. They're a panel of parents, the reasonable patient standard, who have been given enough information that they know they've been really well informed. It takes about a day, and then you have them vote. I have my own views, but my views are just simply not relevant. I also can say that we do fetal palliative care, where families do want to bring the child into the world, they want to meet the child, they want to celebrate the child's life, and they want the child not to have any interventions. And again, I come with no agenda. We can do that. And I don't think that it's simply a therapeutic logic that if you're alive and your heart is beating, we need to start, and you're outside of the womb, that there's a different logic that applies. I do think, though, that there could be a transition that we would eventually get to. Let's say that the Norwood was now completely, not the Norwood, the hypoplastic left heart syndrome, and it's not going to happen, but suppose it was all done by catheterization. Survival, 98%. One procedure. I don't know, can you do that type of thing? Suppose it was, we would have to change our view. So there is a point in the history where we wouldn't necessarily even counsel termination of pregnancy. We'd say, we can do so much for this. Not 10 years ago, but you need to know the current data now. But I'm not the person to make that decision. It would be a panel of people. So really, the ethics of this is I'm irrelevant. I'm trying to set this up and say it's not for us to decide. Yeah.
I think that the problem that I think the problem that we face, though, as surgeons and cardiologists is it's a continuum, and at what point do we draw the line? So, for example, if If a child has a very large ventricular septal defect, would we offer palliative care for that, where we can do a surgery with nearly 100% survival, or maybe 100% survival? But we know that if we don't treat it, they may not die in the newborn period, but they'll ultimately die an ugly death at some point during their life. And there's a continuum from that point to the TAPVD lesion that Mark showed, where there's nothing that we can do. And at what number and at what point in that continuum do you accept that the treatment has gotten so good that you no longer offer that as care? Because I can give you many lesions now that have worse survival, where nobody would even think the surgical mortality is higher, where nobody would even think twice about not offering treatment.
I would assume in that case, though, that as a medical provider, if you were seen in a prenatal consultation, at that point you would not offer termination as the option for treatment for that case. Obviously, that's the choice of the family. But
I think that you're also pointing to the particular issues we've gotten ourselves into about termination in this country and privacy, et cetera. If I said we've done a genetic test on your fetus, and the likelihood that they'll have ALL, low-risk ALL, when they're 4, is 80%, do you want to terminate? We would never let them not treat that. So I think that there's two issues going on here. When in the course of the progression of outcomes do we transition? How do we sort out the heterogeneity amongst the kids who come in? And then this very particular issue is termination decisions prior to birth operate by a fundamentally different logic, a type of privacy, autonomy, that is less so after the baby is born. And that, as we know, is a very contentious issue in our country. And I hear that as well. So I'll let go of that issue, acknowledge it, let go. But I think that the issue that Dr. Cohen is talking to is exactly where do we say the outcomes are good enough, and who gets to decide? Very much an ethical and a political issue. Who gets to decide when the outcomes are good enough we can drop palliation from the discussion?
I think we need to stop. I want to say thank you to Dr. Feudtner and Dr. Cohen, Dr. Lewin.